people towards. Yeah, so a couple of resources in the chat that I'm sharing with folks. I'd love for you to take a look at those and be able to share them with colleagues and others. First is our King County website for vaccines. So we know that we're all working towards trying to improve vaccination rates, and we're trying to improve access as well. King County has a great resource here, allowing people to make appointments at our Kent facility site. There are a lot of appointments. So we vaccinate individuals 6 months and older, regardless of insurance. So if you have patients who are looking for places to vaccinate, can't find it elsewhere, this is a great resource, and you can make appointments online. And then also just pointing people to our respiratory dashboard, which I know some people have been using to kind of guide their practices. We're certainly in the midst of a lot of respiratory transmission. So this is a great way to kind of highlight the importance of that, both for us as clinicians, but also for our patients.
Great, thank you. So Eric, are you okay with me getting started?
Yeah, that sounds great.
All right. Hello, everyone. Welcome to this ACP Long COVID Interest Group. We are very excited to welcome all of you here. And this group started within our Washington chapter for American College of Physicians and supported by our governor, Dr. Chris Knight. Chris is here as well. And we now have members from all over the country. The aim for this group is to exchange information and experiences about long COVID, which is also called PASC, or post-acute sequelae of COVID. It's a condition where not much is known, and the medical and scientific community is coming together to understand more and more. And we want to be able to share it with fellow physicians so that not only we empower ourselves with the knowledge, but also be able to take care of our patients better. I'm Anita Chopra. I'm an internist at UW Medicine. I'm also a physician at the University of Washington Post-COVID Rehab and Recovery Clinic, otherwise called as Long COVID Clinic. I chair the Primary Care Council for the Washington chapter of ACP, and I co-chair the International Medical Graduate Council as well. I am joined today by Nick Franco. Nick is the coordinator for this group. Nick is a research coordinator at the University of Washington Department of Family Medicine. He has been a part of the Seattle Flu Project and has worked extensively in infectious disease and long COVID research. Thank you so much, Nick, for putting together this group and for all your efforts to make this event possible. We are also joined by Ranshirjeet. Ranshirjeet is a medical student and incoming internal medicine resident. Ranshir is passionate about long COVID research as well. Welcome, Ranshir. So we at the UW Post-COVID Clinic, we are dedicated to empowering physicians in the community, and we want to be able to share this information that we have gathered over the past 3 years, and in a series of meetings and in a series of webinars and town halls. And between those town halls, Nick and I will be sharing latest research with you, and Nick will also work on a newsletter. So with this, I want to welcome our distinguished speaker, and I'm so honored to have Dr. Eric Chow. Dr. Chow is Chief of Communicable Diseases, Epidemiology and Immunization, King County Public Health. He is Clinical Assistant Professor, Epidemiology, Medicine, Allergy, and Infectious Disease. Dr. Chow was part of the CDC initial response team when SARS-CoV-2 first hit the US right here in Seattle. And he has been part of the RECOVER study by NIH, which is a nationwide study on long COVID. Welcome, Eric. Thank you so much for giving us time today. You are so gracious with your time, and we are really looking forward to your expertise. Thank you very much for coming today.
Thank you so much for having me and putting together this wonderful program.
So I'm going to start off, Eric, if you can talk to us a little bit about what is the official definition of long COVID, and when does acute COVID turn into PASC or long COVID, and if you can talk about the nomenclature as well.
Yeah, that's a great way to start. Hi, everyone. I'm just going to share my screen and I'm going to get some slides up because I think this is going to be a helpful visual for our discussion today. And please jump in with any questions. I won't be able to see the chat, so if others are able to see the chat for me and read off questions, that'd be great. Again, thanks for having me. This is a real privilege to be here alongside colleagues and people with like-minded interests in better understanding these long-term sequelae of COVID-19. This presentation and the title has been through many iterations at this point, trying to adapt to the evolving landscape and updating knowledge that we have. And for a long while, we were using the terms long COVID. Some people have started to use the term post-acute sequelae of acute COVID-19. And more recently, I've been kind of updating my presentations to try to align with some of the national organizations using post-COVID-19 conditions as kind of a term that is more preferred at this point. But there are different scenarios in different environments, as you'll see in just a bit in answer to Dr. Trover's question, and open to thoughts and discussions as well from the group, and many of you who are probably working in this space as well. And then just to say that I have no disclosures to report. So one of the biggest challenges that we face in this ongoing research within longer term sequelae has been the myriad of terms and case definitions applied. It's really made it quite a hurdle to be able to come to kind of a clinical case definition, to be able to study and compare results between studies due to different terms and case definitions apply. It's like sometimes when you look at different studies and you're trying to understand prevalence, it's comparing apples to oranges depending on the patient populations that they select and the outcomes that they use. So it's all very different. And so fortunately, we've made some headway there, but just to make sure that we're all on the same page. Again, not to insult anyone's intelligence, but I know you're all very familiar with the different disease severity categories for acute COVID-19, ranging from asymptomatic to critical acute COVID-19. Typically, illness course lasts from days to weeks for many people, and then in the weeks to months after recovery, people are at risk for some of the severe complications, including multisystem inflammatory syndrome, described in both children and adults, and of course, today's topic, post-COVID-19 conditions. This is a diagnosis known by many names and definitions, some of which I highlight here. And by no means is this a comprehensive list of all the terms that you're going to see out there, but it's a place to start and probably highlights the more commonly used terms. I also put a link here, and I'm happy to share the slides afterwards, that provides an appendix, a table that outlines all the different terms and the case definitions applied to each of these and which organizations use them as a place for you to kind of figure out what people are talking about. But I want to highlight some of the more common terms that are being used nowadays. And let's see, here we go. So starting with long COVID. So most people are familiar with this term because this is probably the term that was coined way before we even knew that there was an association with these longer term sequelae with acute COVID-19. It's driven by patients' lived experiences, elevated by patients who recognize that they weren't getting back to the baseline health way before I think the scientific, public health, and clinical community recognized that. It's probably most familiar both to clinicians and the lay community, and it's probably most inclusive in terms of the term itself. Includes progressive and relapsing, remitting symptoms. However, I also want to highlight that some people who experience long COVID also don't necessarily identify with the term long COVID. So some people, there is a disagreement there, as highlighted by one of the a really nicely written editorial by someone who has experienced long COVID for the last 3 years, stating that long COVID doesn't necessarily represent what they experience from acute infection to the symptoms that they have now. It's not long COVID in the sense that they had symptoms from the time that they had acute COVID-19 that carries over. It's distinct. People experience very different symptoms after acute infection. So the term long COVID doesn't apply to their particular situation. So just wanted to put that out there, even though it's probably most inclusive and most commonly used, not everyone who experiences these post-COVID-19 conditions identify with the term long COVID. There's also post-COVID-19 conditions, which has been adopted as a term by CDC, WHO, and IDSA. more commonly used in the medical, scientific, and public health communities. It's essentially equivalent to the term long COVID, which includes direct and indirect effects and complications caused by the virus. And for the most part, these are physical and mental health consequences that are present 4 or more weeks after acute infection, with some variations in case definition by organization. And some people will continue to hear the term PASC. So PASC continues to exist today to describe post-acute sequelae of SARS-CoV-2 infection, or some people say post-acute sequelae of acute COVID-19, mostly because this is the term that has been adopted by NIH in their RECOVER study. Some of you probably have heard of it or have been a part of this. That has been longitudinally following patients, both those who had never had acute COVID-19, those people had prior history of acute COVID-19, and they're following their symptoms over time and complications. Subset of these people will go on to develop post-COVID-19 conditions, and I'll highlight some of these studies later in the presentation, but this is why this term continues to be used. And for those people who are familiar with administrative codes, you're probably aware that there is an ICD code U09.9 that has been used to help people classify certain visits as being associated with post-COVID-19 conditions. Again, we know that when people use ICD codes or administrative coding to do studies, there are some limitations, misclassification, et cetera, but just to say that it is there. And there's also a term used by the UK organization NICE that also uses the term post-COVID-19 syndrome, slightly different case definition. Again, just to highlight how complicated the landscape is when it comes to terms and case definitions. And coming back to kind of the WHO piece, one of the questions that Dr. Tober brought up is like, what is that transition point from acute COVID-19 to longer term sequelae or post-COVID-19 conditions? It depends on who you ask. Based on WHO definition, which has been put together through a Delphi approach, collaborative approach, including community stakeholders, scientists, policymakers, patients, different groups, they push for a longer kind of duration, so 3 months. With symptoms lasting at least 2 months, whereas CDC, as you'll see in a bit, is more on the other side, on the other end, so 4 weeks or more. So it depends on the organization, depends on the study, depends on who you're asking. So there's still a little bit of variability there. But fortunately, there's maybe some headway here to kind of unify us behind a specific term and specific case definition. And this is led by the National Academies, which has been putting together a working group to really study this, to bring in different perspectives, to put together a working definition, understanding that as we learn more about this condition, we're going to have to update it. So working off of this kind of base definition, which I'm not going to read here, but I'll leave as a resource for those who want to dig into it a little bit further. The HHS has this definition. It's very, very comprehensive, very, very long. But the purpose is that this should encompass a large group of people, until we can better understand and refine our case definitions to understand what truly is leading to post-COVID-19 conditions. And then I have a couple slides here that highlight a report that highlight, different feedback that they've received from different groups that they've worked with and upcoming events to further refine this definition. But in terms of like what definition I typically go to be able to help, most people that I'm speaking with understand what we're talking about, I really like these CDC definitions that they continue to use on their website. And I think this is simple and really straightforward. Essentially, these are health consequences, physical and mental, that can be present 4 or more weeks after infection with SARS-CoV-2, or instances in which there is a lack of return to a usual state of health following acute COVID-19. And so, which definition you should use or should officially use at this point, I think really depends on the environment that you're in and the people that you're speaking with. But I think, in terms of just an overall kind of definition, I really like these CDC case definitions as a kind of a starting point for a conversation, just trying to get people to know more about these longer term health burdens associated with COVID. So.
Thank you so much, Eric, for this amazing, information, and it's really eye-opening. And the fact that you showed us WHO and CDC definitions, I think that one very important aspect is that there are about 23 million Americans impacted by long COVID, and chances are that most of us, physicians here have seen, patients in our practice who have presented with lingering symptoms after acute COVID infection. Here at the University of Washington Long COVID Clinic, we do use codes for PASC, post-acute sequelae, or post-COVID conditions. Those are some of the codes, the broader codes that we use, in addition to more specific codes on chronic fatigue or cognitive decline, which we will subsequently talk. Thank you so much, Eric, for this. When we see patients at the clinic, Eric, some of them have had upper respiratory infections in early 2020. There was no diagnosis or no diagnostic tests for COVID even, and they have lingering symptoms since then. Do we call them as having post-COVID conditions?
Yeah, that's a really great question. One that I know that we're all kind of challenged with, because I think a lot of people just want to have a diagnosis, right? I think the truth is that it's difficult to be able to necessarily to start to differentiate, because I think there's probably going to be a lot of etiologies that's going to be uncovered that's due to COVID and other things that also look like long COVID. But I think in that situation, when we're seeing patients in clinic, I think it's less important about defining it as long COVID. It's more important to address kind of the health consequences that people are experiencing. It is true, right? We all remember at the beginning of the pandemic, testing was very limited. And for a lot of people, testing just simply wasn't available. And for a lot of people nowadays, testing is also not available. And if we only are willing to treat those people who have prior laboratory confirmation of COVID, I think we're going to be exacerbating health disparities that continue to exist. So those people who don't necessarily have the means to access testing or purchase testing, and either at the beginning of the pandemic, throughout the pandemic, or now, they're not going to get the same level of care that they should be getting, regardless of whether they have the ability to prove that they previously had COVID-19. It is on researchers, clinicians, public health people, researchers to help us further define and refine to be able to understand. But as clinicians, I think we still have a responsibility to help address whatever it is, the health consequences that people have coming to the clinic, and not pigeonhole ourselves into only thinking we're going to be treating just this one very select group of people. Because again, the last thing we want to do is exacerbate health disparities or create further distress to patients who are really asking for our help.
Thank you. And in our clinic here at University of Washington, we are still seeing patients who are presenting with symptoms lingering on since they first had COVID, either in 2020 or 2021. And so we are seeing patients with 3 or more years of symptoms, especially due to the long wait times for this clinic and the poor access due to the limited number of physicians that there are. We are still seeing patients who had initial, start of symptoms 2 years ago or 3 years ago. So Eric, from here, I want to talk a little bit about the disease burden. How prevalent is it? I know I threw out the number 23 million. And what is the healthcare cost of this condition? And in terms of the epidemiology, what is the healthcare burden of this condition?
Yeah, it's a very common question that I get. And it's, again, also very difficult to quantify for the reasons that I highlighted earlier. But if we were to maybe try to put it into context, I want to share a few slides that I frequently try to bring people back to. Earlier in the pandemic, as we all probably recall, we were putting out numbers of 100,000 deaths, and we were saying that that was going to be just a significant, oh my gosh, I can't believe that COVID would cause that many people to die. At this point, we're at at 1.1 million deaths nationwide and 6.5 million hospitalizations, again, highlighting the ongoing burden associated with COVID-19. As many as 1,000 deaths continue to be reported to the CDC each week due to COVID-19. So many people want to move beyond the disease and stop talking about COVID, but I wouldn't be doing my job as a public health person. We have a duty as physicians to highlight the ongoing kind of risk. And again, I appreciate having this group here because one of the things I don't think we talk about enough is the health burden associated with post-COVID-19 conditions. I think one of the challenges is being able to quantify it, right? Most people want to see a number. And so some studies have attempted to be able to calculate this, again, limited by the fact that these are different patient populations that they're looking at different points in time, not always having an appropriate control group to be able to compare to, but people have given some ideas to what the range might be. I highlight some of these studies here for you to use to equip yourselves with like this additional knowledge that you can share with patients. But when put together, and there's this really wonderful review by Dr. Eric Topol recently in Nature Reviews Microbiology that really summarizes the literature. And they estimate from all the literature that they review that anywhere from 10 to 30% of non-hospitalized cases, 50 to 70% of hospitalized cases, and 10 to 12% of vaccinated cases go on to develop post-COVID-19 conditions. And again, there's a lot of reasons why this is possibly an undercount as well. We know that cases aren't always reported. Not everyone is testing. So the true number is probably, we're not really ever going to be able to get to it, but this is kind of our best estimates. And I think it's reasonable for us to be able to use this to then highlight the importance of ongoing mitigation efforts, for ourselves, our loved ones, and our community. But even if you were to take conservative numbers, such as the reported number of COVID-19 cases reported to WHO, which we know this is underreport, right, due to access to testing limitations, reporting limitations, human behavior change. But as of December 31st, the WHO estimates that there's been greater than 773 million COVID-19 cases. And even if you take this conservative number of 10% of people who go on to develop post-COVID-19 conditions, that means that at least 77 million people have had or is currently experiencing a post-COVID-19 condition. And again, this is probably a vast underestimation for a number of different reasons. From the economic side, when you're talking to people, well, why should I care? It's not affecting me. People sometimes understand money a little bit better. So we try to quantify this through various estimates. Earlier, I think this is from 2022, the Brookings Institute tried to estimate the number of unfilled jobs due to long COVID. And they estimate that as many as 15% of the nation's unfilled jobs at the time were due to long COVID, which is a startling number when you think about it. In New York State, they estimate that those people who experienced long COVID, about 18% of them could not return to work for more than a year. And we have more recent estimates, and I put some resources here for you to all take a look at a little bit later. Some updated estimates suggest that 44% of people with post-COVID-19 conditions cannot work. And those that do work 51% fewer hours. Some people, if you project that if you were equating the healthcare costs of post-COVID-19 conditions with a more familiar kind of syndrome, chronic fatigue syndrome, individuals could be paying up to $9,000 in healthcare costs per person annually. That's a substantial amount of economic burden on individuals, especially those people who already are strapped in terms of financial resources. And more recently, there's this, I just found this new updated report that shows that as of January 2022, the cost of post-COVID-19 conditions, both from lost wages, medical expenses in the US, is estimated to be greater than $386 billion. I saw that, I was like, oh my gosh. There's more work to be done to be able to provide this forecasting to, again, highlight the importance of this issue. But even from these numbers, I think we're already kind of showing that there's a lot of work to do here, and we need to do it now.
Thank you for sharing this. And one very important thing, and these are startling numbers, but there is also a very important aspect which affects us physicians, especially the primary care physicians, is that when you see your patients who are going through, long COVID conditions or experiencing post-COVID conditions, they will often come to you with disability paperwork. And that is where primary care docs will need to, we will need to sort of update our skills as to what is it that we, need to do next. And that's where, a lot of our sort of resources at our disposal, we need to know what resources do we have at our disposal. And in subsequent talks, we will, talk about those as well. Talking about my own personal experiences, that when I joined the post-COVID clinic, I was not prepared for the amount of paperwork that awaited me. So with each patient, there was disability paperwork. And in full disclosure, none of us likes paperwork, but this is something that, we probably need to, get used to, because at some point they will file for disability. Eric, my next question talks about, comorbidities, and are there any populations or any patients or any conditions that make people more susceptible to developing post, COVID conditions? Any gender differences or anything that makes people more susceptible?
Yeah, also an excellent question, one that I know is at the forefront of everyone's mind when they're looking at risk factors associated with the subsequent development of post-COVID-19 conditions. First and foremost, we're looking at, people have been looking at age and other demographic risk factors. We know that with age, that people of all ages are at risk for post-COVID-19 conditions, children and adults. Some of the reports estimate that probably the highest percentages of diagnoses of post-COVID-19 conditions happens between 30 to 50 years of age. That also makes sense because that is probably the age group that maybe takes a little bit fewer precautions and also are likely to have increased infections. Again, this is something that will probably pan out as we understand post-COVID-19 conditions a little bit better, to be able to understand what exactly are the factors that are contributing to higher percentages in this specific group. The risk also appears to be higher in older age groups with similar acute disease severity, but we also know this age group is closely intertwined in terms of risk for, this age is has greater risk for acute, more severe acute COVID-19, which also influences your subsequent risk of post-COVID-19 conditions. I just want to highlight again a couple of great MMWR reports that were published, I believe, last year that highlight that very elegantly highlight some of the risks for certain health conditions, both in adults and children. Specifically, they look at, within adults, different organ systems, conditions that we're very familiar with, right? Acute myocardial infarction, cardiac dysrhythmias, all the way to type 1 and type 2 diabetes. And it just runs through all the different organ systems in the body, and, varying by condition, there's different risk of those people who go on to develop these diagnoses after a previous history of post-COVID-19 condition. After a history of COVID-19. And one of the things that's been really challenging on my end from the public health perspective is a lot of people perceive COVID to not be a real threat for children. And I really try to remind people that there are longer term health conditions that are more common in children with prior history of post-COVID, with a history of COVID-19. And this is also highlighted in this MMWR, ranging from hematologic abnormalities, obviously lung issues, fatigue, heart conditions, and such. So, this is an ongoing area of research. The clinical phenotype does seem to be different between younger age groups and older age groups, but there are longer term complications, and hence why mitigation efforts across the age range remains important. Other factors, of course, the increase in severity also seems to increase your risk of acute COVID-19, although people of all acute disease severities are at risk for subsequently developing post-COVID-19 conditions. We do see probably more post-COVID-19 conditions among those people with mild infection, but that's probably because there are so many more people who have had asymptomatic or mild infections. Of course, like I mentioned before, people with more severe acute COVID-19 are more likely to develop post-COVID-19 conditions. Some people ask, how does that vary between different variants? Again, also hard to say because we haven't had genomic sequencing the entire time for every specimen. We also haven't, we're continuing to refine our definition for post-COVID-19 condition. We haven't always applied the same post-COVID-19 definition across all different phases of the pandemic. But what I can say is that even at this point, when we have increased community immunity during this period with Omicron, where we see fewer cases of severe disease, we still see post-COVID-19 conditions. And we still see it among those people who have been had prior infections, have had prior vaccination, and that risk still remains. Interestingly, if you take a look at some of the, to get to the question about, other demographic risk factors and gender, interestingly, in many of the reports, we do see an increase in prevalence of cases of post-COVID-19 conditions in women. It's unclear, however, whether it's better recognized in women or whether women are more likely to seek care, which are two possible factors that may see an increase in those cases in that specific gender. But more research needs to kind of go into this. And then hopefully studies like the RECOVER study are be able to provide more data on that end. And I also want to highlight this because this is really an important piece to any discussion about COVID and just any health conditions in general, right? A lot of our focus here in King County, and I'm really proud of the work that we do, not just within the public health realms, but within our clinical realms, is we're trying to address racial and ethnic disparities, which have been certainly exacerbated by the pandemic. Right. And we know that from the beginning of the pandemic, there have been disparities when it comes to COVID-19 outcomes. And when compared to white populations, Black and Hispanic populations have increased rates of SARS-CoV-2 infections and increased risks of hospitalizations. And even though we don't yet have defined data to be able to say that Black and Hispanic populations have increased risk for post-COVID-19 conditions, just by virtue of them being at greater risk for SARS-CoV-2 infections and greater severity of disease during acute infection, certainly would lead you to then think that there is a greater risk than for post-COVID-19 conditions, and we need to address that disparity. Some early findings from some studies looking at racial and ethnic disparities have shown that Black and Hispanic populations present with different types of phenotypes of post-COVID-19 conditions when compared to white individuals. I think the takeaway here is that when we're looking at these longitudinal studies, such as the RECOVER study, this is why it's so important to have a diverse study population to be able to represent the breadth and the clinical spectrum of different post-COVID-19 conditions. Also, some early studies, as highlighted by this paper published in PMR, they found that in this patient population, Black populations had lower utilization of outpatient rehabilitation services despite similar incidence of post-COVID-19 conditions. So we're already seeing some disparities in the early research in this area. And the one thing I also want to highlight, just to arm people with information so that you can take it back to patients for why it's still important to reduce risk of COVID. A lot of people are like, oh, I've had COVID previously. I've never had long COVID or never had post-COVID-19 conditions. I'm probably going to be fine. The reality is that that might not be true. Several studies, including these two highlighted here, have already shown that actually SARS-CoV-2 reinfection is associated with a higher risk of subsequent development of sequelae. Some have suggested that there's a cumulative risk that increases with the total number of infections. So each subsequent infection will continue to add to your risk of longer-term symptoms. So that is not a risk that I would want to take, even if I've had COVID before. So just want to share that with all of you.
I think that was really, really great information, and I'm so glad that you touched upon pediatric population, because we do see in our post-COVID clinic, we do see kids, and we have some physicians who manage the post-COVID condition in children, and we do have a large patient population of kids. That is one thing. And the other really important thing that you mentioned is increasing risk of developing post-COVID conditions with repeated or recurring acute COVID episodes. And what we see clinically in patients is that every time they have an acute COVID infection is a setback to them clinically. And I just saw this lady yesterday who had COVID 4 times, and each time any progress that she had made, she it was a setback to her, and she went back to point zero. So I think that is a very important thing for us physicians to remember. Let's talk a little bit about I think that this is the most important thing, and it's quite fascinating, is the pathophysiology. We do have some hypotheses about the post-COVID conditions. What are some of the reasons, why people develop it?
Yeah, I find this area of research fascinating because it's uncovering just a lot of things that we just previously didn't even know about our own bodies. And so it has also kind of opened up doors for research for other type of post-viral illnesses, post-viral illness-like conditions. And so this is just a highlight. This figure just highlights some of the hypotheses as to, what is kind of going on. There are really great kind of comprehensive reviews out there. I can also share some of those with you. Again, going back to the paper that I've referenced the most, Dr. Eric Topol's paper in Nature Reviews Microbiology, which really outlines the research up to this point. They've highlighted that, there are many reasons for why there might be post-COVID-19 conditions. It could be in combination with these different factors, or it could be, individual factors affecting different people differently, leading to this very different clinical phenotypes that people are presenting with. For some people, it's immune dysregulation. Sometimes it's in combination with microbial flora disruption, autoimmunity, hypercoagulability, or just endothelial dysfunction, and of course dysfunctional neurological signaling, which a lot of people believe to be the cause for a lot of symptoms that people are experiencing. One area that I find very interesting is the gut microbiota kind of like hypothesis, and these couple of studies showed that gut microbiome is significantly altered in those people with COVID-19 compared to those without. The commensals, so the good bacteria that are associated with helping us modulate our immune system, are frequently underrepresented in those people with prior acute COVID-19 and go on to develop longer-term symptoms. This disruption seems to also be associated with elevated inflammatory markers. So whether one causes the other, or which direction it goes is yet to be determined, but it is for those people in the inflammatory state of the acute infection certainly have a disruption in the normal kind of makeup of their microbial flora. And this continued dysbiosis seems to continue into the post-COVID-19 condition kind of time period, and seems to be able to distinguish people who have these lingering symptoms compared to those who went on to recover and get back to their baseline. Another interesting study, and I highlight this, both because it's interesting, but also because it's conducted by folks here. And I believe, Nick, you contributed to this paper as well, published in Cell just about a year ago, highlighted by the New York Times, mostly because this is one of the first studies to really highlight some markers that could help identify individuals who would go on to develop post-COVID-19 conditions. In this paper, they reference it as past or post-acute COVID-19 sequelae. So really a great study. They looked at clinical specimens collected from individuals during their acute infection across a range of different disease severities. They compared them to healthy controls, and they followed them over time. They did a number of different studies and research studies, some of which I can't even pronounce. But in the end, they were able to identify 4 factors that seem to be able to predict who would then subsequently develop post-COVID-19 conditions or PASC. This includes people with pre-existing type 2 diabetes, SARS-CoV-2 RNA levels at acute infection, EBV viral levels at acute infection, and autoantibody development at acute infection. And I emphasize acute infection because by the time people develop these longer-term symptoms, these were no longer measurable, of course, with the exception of type 2 diabetes, but the rest of them were no longer measurable. So it was at acute infection that these were measured, and they were able to subsequently predict who would then go on to develop these longer-term symptoms. So again, very interesting, not yet clinically actionable. We can't necessarily be measuring all these tests in everyone. And it's not entirely clear necessarily what the associations mean, but it is certainly a hypothesis worth further investigation. The other thing that Dr. Heath's group also did here that I thought was really illuminating is that regardless of your disease severity, when you look at the T cell populations and other immune kind of subtypes, people start to, when they recover from their acute infection, they start to develop and start to move into these specific endotypes or signatures. And some of these signatures seem to be associated with specific post-COVID-19 condition presentations, such as those who primarily have gastrointestinal symptoms. So certainly really interesting. And Dr. Chopra, if you're okay, I'm going to jump right into kind of that serotonin reduction hypothesis, which was highlighted by a very interesting paper published in Cell very recently. And I think this is worth a discussion because this really highlights, it's actually a really well-written study. I oftentimes personally get intimidated by studies focused mostly on molecular biology and immunology, mostly because I read the acronyms and it's way over my head. But I found this really to be well-written and you can follow along really nicely. So I encourage you all to take a look at it, but I try to summarize it here. But going back to our diagram, they highlight that there are 4 pathways that get incorporated into the serotonin hypothesis, hence why it's worth kind of further investigation and may explain why some people go on to develop these really debilitating long-term symptoms. And they highlight this as viral persistence, chronic inflammation, clotting dysfunction, and autonomic dysfunction. So when we look at on the left here, you see a figure of different types of presentations of post-COVID-19 conditions. This is supposed to symbolize people with long COVID, but basically they looked at plasma metabolomics in patients with long COVID. They developed a metabolite profile looking at those people who had recovered and are symptom-free and compared it to those people who continue to experience symptoms. And they noticed that serotonin levels really stood out, and notably serotonin levels at acute infection and for those people who go on to develop post-COVID-19 conditions remain really, really low. And we know that serotonin levels play a very important function as a neurotransmitter in our bodies. And so is there something there? Is there a big question? So they noticed again that serotonin levels are low, so they start to investigate this hypothesis and possible pathway for why this might be happening. So you look at a mouse model to be able to further develop their hypothesis. So what they noticed, starting on the left and moving over to the right, they started to see in these mouse models that if you decrease in serotonin was found in SARS-CoV-2 infection, but not just in SARS-CoV-2 infection, but other viruses that also cause systemic disease. And so just to say that COVID may not be the only virus that can cause these longer term kind of sequelae. They noticed that serotonin levels were recovered in low serotonin levels were seen in those people with longer term sequelae, but for those people who cleared the infection and actually got better, don't have these persistent symptoms, they return back to normal. So they noticed that in the models where they had chronic viral persistence or infection, that serotonin level remained low. So the big question was, is it possible that there is some sort of COVID viral persistence in these individuals? Again, an interesting hypothesis that certainly warrants further study. They noticed that in mice with persistent viral infection was associated with higher levels of interferon-stimulated genes, which is also seen in long COVID patients, trying to tie together this hypothesis. And, as many people may be aware, serotonin in our bodies is produced in the GI tract, not just in the brain, but it's produced in the GI tract from the precursors, dietary precursors, such as tryptophan. And people with acute COVID-19 and long COVID have reduced plasma tryptophan levels, suggesting that inflammation seems to tampen down our ability to absorb tryptophan, this important precursor for serotonin. So how is this all kind of tying together? Well, because of this decrease in tryptophan, we have less serotonin in our body, leading to, these potential kind of longer term complications. Other hypotheses that tie together kind of the platelet hypercoagulability piece is that serotonin in plasma is also carried on platelets, actually something that I didn't previously know. And so we know that during acute infection, some people go on to develop low platelet counts and also have hypercoagulability as a result of hyperstimulation of platelets. And so when platelets are consumed, you no longer have that transport mechanism for serotonin, and serotonin quickly breaks down in the plasma. So again, supporting this idea that this persistence or this ongoing inflammation resulting in decreases in overall body serotonin may be contributing to some of these effects that people are experiencing. And again, serotonin in their study also seemed to disproportionately impact the vagal neurons and the hippocampus. And as you're aware, the hippocampus is where a lot of our short-term memories are formed. And for people who are dealing with brain fog, this might be one of those kind of explanations. Interestingly, serotonin in the brain doesn't seem to be affected by viral inflammation as much as the peripheral serotonin levels, which highlights again that it's really in the gut. Where the ongoing inflammation that people are experiencing is impacting the serotonin, leading to these longer term sequelae. So an area that certainly deserves further research would be an important area for kind of clinical trials potentially down the road. We have a lot of treatments already to help people boost serotonin levels, and this might be worth further investigation.
I think this is a very, very fascinating, very interesting study on so many different levels. It not only highlights the importance of the gut-brain axis, it also probably, gives a lot of importance to, or sort of, I would say, highlights the importance of SSRIs. And, talking from a clinical perspective, we have seen patients in our long COVID or post-COVID clinic who have experienced benefit after they started SSRIs for depression or anxiety. They noticed that their fatigue, there was improvement in fatigue, there was improvement in brain fog, and there may be a link to this underlying mechanism or the underlying pathophysiology. So I think, like you said, there's going to be probably a lot of interest in this area. So this is wonderful information. And Eric, I want to talk a little bit about symptoms. I know that you mentioned, a lot of the patterns of symptoms in adults and in kids, but we know now that the long COVID symptoms, they tend to have patterns, or they are seen in clusters. So let's talk a little bit about symptoms, as to what we see in a clinical picture. And I will also share my experience in the clinic.
Yeah, that sounds great. Yeah, another important area of research. There are a lot of symptoms, signs, symptoms, and conditions that are attributed to COVID-19. One report has summarized over 200 symptoms that seem to be associated with post-COVID-19 conditions. And I think some work has been done in this area, again, thanks to the RECOVER study, that has been trying to help better define what post-COVID-19 conditions are and answer the question as to whether there are different potential clinical phenotypes that may warrant specific investigations for each phenotype. And for those people who may have not read it yet, but this paper published in JAMA, I think, is one of the first papers to come out from the RECOVER study to be able to develop a definition, start the work to develop a definition for post-acute sequelae of SARS-CoV-2 infection or post-COVID-19 conditions. And they do so through a very comprehensive process. Now, just to give you a little bit of background in terms of the study itself, they recruited people who are what they call, and included them in their acute cohort. And these are people with SARS-CoV-2 infection and are recruited within 30 days after their acute infection was detected. They also have a post-acute cohort. These are individuals who are included between 30 days to 3 years after their acute infection. And fortunately, very astute researchers, including Helen Chu's group, started collecting information about individuals who've never had SARS-CoV-2 infection and have clinical specimens to provide adequate kind of control and comparison groups. And so this has been included as part of this RECOVER study so that you have an appropriate control group to see whether this increase is truly solely attributable to acute COVID-19. And they've recruited people from different periods of the pandemic, probably affected by different SARS-CoV-2 variants. There are about 85 sites across the US from which people are recruited. There's a lot of diversity there. And they identified about, I believe there's, they looked at a number of different symptoms, but what came to the surface included some of the symptoms that I highlight here, including malaise, fatigue, brain fog, dizziness, gastrointestinal symptoms, palpitations, kind of change in sexual desire and capacity, loss of changes, smell or taste, chronic cough, thirst, interestingly, chest pain and abnormal movements were some of the more commonly described symptoms. And so when those came out to the surface, they were able to then take these symptoms and started to develop a PASS score. And the goal of this was to be able to apply a score to individuals with these symptoms to then determine whether they did or did not have PASS. I think in the development of the study, I think the goal was to develop a indicator more for research than it is for clinical use. But interestingly, I think it's still interesting for all of us as we're kind of learning more about post-COVID-19 conditions. So basically, they assigned each of these symptoms a value. They totaled the scores together to be able to provide an individual their PASS score, post-COVID-19 condition score. And then they use a cutoff of 12 or greater to be able to differentiate those with PASS and those without PASS. What they found was among their cohort is that among the infected cohort, 23% were PASS positive. So 23% of those people with a prior history of acute COVID-19 had a score of 12 or higher. Among the acute cohort during the Omicron period, so 2022 onward, 10% were PASS positive. We should also highlight and note that those people who never had a history of COVID-19, a portion of them also fulfilled the criteria for PASS by being above the score cutoff. And I think this highlights why it's so important for us to carefully study this and have appropriate control groups, because a subset of people, some of these conditions that people experience and symptoms that people experience are just very common chronic conditions. And to be able to differentiate and not to misclassify people, we need to be able to conduct studies like this. So I want to highlight that element. Also, interestingly, they looked at the individuals who were identified with PASS, and they used statistical modeling to be able to group certain phenotypes together. And their statistical analysis came up with 4 distinct cluster groups where symptoms seemed to cluster together. They identified in this study that one group was very distinctively those people who continue to experience anosmia or dysgeusia, and then another group that was solely malaise, one that was brain fog, malaise, and fatigue, and then another one that is an amalgam of different symptoms that people experience. So, this is the type of statistical analyses and the comprehensive look that we really need to take to apply to understanding post-COVID-19 conditions. And while this study came up with about 4 clinical phenotypes, it's quite possible there are so many more out there, depending on the patient populations we're looking at. But being able to categorize and differentiate different clinical phenotypes may also then be able to help us understand what type of studies we need to conduct to look at the specific pathophysiology that then leads to these specific pathways and different outcomes. But from a clinical standpoint, I want to point to a really important resource from the American Academy of Physical Medicine and Rehabilitation, because I think a lot of people are trying to figure out, where do I turn to for information to be able to help my patient? Each patient seems so different. And that's true, right? As we saw, there are over 200 signs, symptoms, and conditions that we've had to be looking out for. But very appreciative of our clinical colleagues who are out there, who have been really doing this work since the beginning of the pandemic, who have helped to put together some useful information to help clinicians support their patients. And so the consensus guidance documents are highlighted here on the website, and you can click through, and there's kind of step-by-step kind of strategies on how to help people with specific conditions, including those who happen to be, for your pediatrician colleagues, please also share out this guidance, because there's one specific to pediatric populations.
I think this is an excellent resource for all physicians, and especially primary care physicians. We do follow AAPM&R guidelines in task management, and they are consensus guidelines, very comprehensive, talking about all different symptoms and what are the management strategies. And as Eric mentioned, clinically we see clusters and patterns. For example, we will see patients with anosmia or parosmia, along with brain fog, cognitive changes, memory changes, word recall. That would be one cluster. We would see those patients often together with overlapping chronic fatigue, malaise. And then we may see cardiovascular clusters or patterns with tachycardia, hypotension, dysautonomia, POTS-like symptoms, often associated with shortness of breath. Those would be another pattern of presentation. And then we see GI symptoms, diarrhea, nausea, along with dysgeusia, and often associated with chronic fatigue, decreased endurance. Those are some of the patterns, different patterns, and most commonly we will see patients, the most common presenting complaints are chronic fatigue and brain fog. So I think in our clinical practice, it's, you will see these distinct patterns when patients are presenting with post-COVID conditions. In the interest of time, Eric, the next question is so very important, but yes, yet the answers are so very vague. Is there a specific test to diagnose this condition?
Yeah, great question. And the reality is that there isn't. There isn't one test to be able to tell us whether someone has a post-COVID-19 condition or not, unfortunately. And I know that creates some challenges in the clinical space, but it also is an important point to highlight that this is our time to be able to take in information from our patients, right? To be able to kind of gather all the information, be open-minded, and hear the patient's story. Oftentimes by the time a patient comes to your clinic, sharing with you that they've had these lingering symptoms, they've probably been to other providers where they have been stereotyped or judged in a certain way that really makes it difficult for them to kind of move forward. For a lot of people who are maybe less familiar with the fact that post-COVID-19 conditions are so prevalent, they may think that they're the only people who can't seem to recover or get over their acute infection. There's a lot of depression, mental health consequences as a result of kind of this mentality, and certainly after being passed between different clinicians without a pathway forward. So one of the most important thing, certainly, that has been a lesson learned, I think, for all clinicians, has been that when someone does come forward and is sharing this information with you, is to keep an open mind. And even though, tests that they have done up until this point are all negative or unrevealing, doesn't necessarily negate what they're experiencing or negate the fact that they're experiencing a post-COVID-19 condition. And it's also not necessary to perform tests just because someone has a post-COVID-19 condition. I think at some point we used to kind of shotgun approach and send every lab under the sun to be able to figure out what is going on with folks. But that creates a lot of cost and anxiety, especially when you have test results that you don't necessarily know how to interpret. I can tell you, I'll share personally that, certainly I regret there are those moments where I would send a test and I didn't fully understand what I was looking for a specific test, and then you get back an abnormal value, and you're not sure how to interpret. It creates a lot of challenges, not just clinically, but also for the patient. So what I would say is like, be very thoughtful about the approach when it comes to laboratory testing and understanding the risk benefits and certainly the costs that the patient will incur. And again, there isn't necessarily any one laboratory test out there, but this is that time where it really requires us to keep an open ear and keep an open mind with regards to what a patient is experiencing.
So well said. And there's definitely not any one single test, as Eric said, and but it's very important to listen to the patients, because often they feel that they are not heard and that no one believes them. And I think that's very, very important. And Eric, as an infectious disease doc, I would be remiss if I wouldn't ask you this question. Is there any way or any measures that can prevent people from developing long COVID? Is there a role of vaccines or Paxlovid or anything that can prevent it?
A great way to kind of bring things together. And this is something that we've really been trying to improve our messaging on and try to ensure that there's maximum uptake, particularly among those people who are at greatest risk, right? Here, actually, I'm going to start with this slide because I think this is the best place to start. So what are the ways in which we can reduce our risks of post-COVID-19 conditions? And, just a couple of years ago, we had very scant data to be able to kind of support approaches in messaging. But fortunately, we've seen a lot of progress in the area that has shown that certainly from a vaccine standpoint, staying up to date with recommended vaccinations is a sure way to be able to reduce your risk of subsequent development of post-COVID-19 conditions. This has been shown and repeated across a number of different studies, including the study that I described earlier by the RECOVER study, where they showed lower risk of post-COVID-19 conditions in those people who were previously vaccinated. And in summary of all these different study results, basically, the more vaccinations that a person previously has had, there seems to be a greater risk reduction in subsequent development of post-COVID-19 condition. But we also know from the data that I presented earlier, 10 to 12% of people previously vaccinated still go on to develop post-COVID-19 conditions. That's why we continue to advocate that layered approaches is still important. Both vaccination plus masking in indoor crowded spaces, improving ventilation are all kind of critical pieces. And a really important area of study has been the use of Paxlovid and other kind of antivirals for the prevention of subsequent development of post-COVID-19 conditions. And a number of studies that I highlight here have shown mixed results. From one study showing early use of nirmatrelvir or Paxlovid during acute infection reduced subsequent development of post-COVID-19 conditions, whereas other studies looking at different patient populations and using different types of methodologies haven't shown such a robust decrease. So they weren't able to kind of show that type of benefit. But what I would say is that I think the logic here is simple. Is that anytime we increase the risk, anytime there's an increased risk for more severe acute COVID-19, there's increase in your risk for subsequent development of post-COVID-19 conditions, right? And so whatever you can do to reduce your risk of severe acute COVID-19, whether it be through vaccination, staying up to date with the updated vaccination recommendations, or reducing your risk with early testing and early treatment, if you're eligible with some of the antivirals, will decrease your risk of post-COVID-19 conditions subsequently. And the last thing I'll say is that, again, the most important thing here that I think people should take away and reiterate to their patients is staying up to date with recommended vaccinations is one thing, but layered approaches are still really important, especially now when transmission is high. Masking in indoor public spaces, crowded areas, improving ventilation where it's safe, and of course, early testing, early treatment, if eligible, are all really critical, still important elements to our protection of reducing risk of severe diseases associated with acute COVID-19 and subsequent development of post-COVID-19 conditions.
Thank you so much, Eric. This has been such wonderful and such valuable information, and this just kickstarts our journey for information sharing with our ACP members and physicians. And thank you so much for your time and for sharing this information with us. And I really, really appreciate you coming in today and especially giving your point of view as an epidemiologist and infectious disease doc. Thank you very much. And over to you, Nick.
Yeah, thank you so much. And I just wanted to say we're going to be sending out a newsletter at some point in the near future. And then also feel free to reach out with any ideas for topics to cover, any potential speakers, or feedback on any of these sessions. And thanks.
Thank you very much.
Thank you, everyone.
Thank you, everyone. Thank you, everyone.